Hello, welcome to our new medical series, Call to Care by Sanford Health. I'm your host, Courtney Collin. Call to Care brings forward medical experts to give fellow clinicians some advice and guidance that they can use in their primary care practice and information about when it's time to refer patients and families to more specialized care. Joining me for 6 episodes focusing on children's care is Dr. Joseph Sejlan. He's the Vice President and Medical Officer for Sanford Children's Hospital and a leader in pediatric critical care. And he has narrowed down 6 timely topics for us. Good to see you, Dr. Sejlan.
Yeah, good to see you as well, Courtney.
We're happy to have you here. And in this episode specifically, we're talking about decreasing antibiotic usage in urgent and primary care. Dr. Sejlan, first, tell us why you chose this topic.
Well, I think anybody who takes care of children and, importantly, takes care of children's parents are often have the issue of, does my child need antibiotics or don't they need antibiotics? And that can be a real difficult judgment call. And I think that our expert today will really help narrow that down and provide some valuable guidance.
And speaking of, let's welcome Dr. Fernando Bula-Rudas to the conversation today. Good to see you.
Good to see you, and thank you for having me here.
Yeah, Dr. Sejlan, tell us, why you chose Dr. Bula-Rudas.
Well, at Sanford Children's, we're really just incredibly fortunate to have some great pediatric infectious disease physicians who really are the experts in febrile illnesses and infectious illnesses for children, both in the hospital and also as an outpatient. And so that's why I thought that Dr. Bula-Rudas' expertise would be a great way to tip off this series and give some great advice for providers. Dr. Bula-Rudas, maybe perhaps we'll start by just saying, what is a pediatric infectious disease specialist? What kind of training have you had?
So, just as he says, we treat mainly infectious diseases in children. We treat both outpatient and inpatient. We combine both of our settings. Complicated infections in the hospital. Also, we do infection prevention, the strategies to prevent healthcare-associated infections, and also we manage the outpatient setting, kids that do not need to be admitted and can be managed as an outpatient.
Thanks. I know with my own children, and certainly when you talk to other parents, it seems like kids are sick a lot, especially when they're young. And there's a fair amount of pressure when kids have febrile illnesses, especially with whether it's getting back to daycare, parents going back to work, permission to go back to school. So I can feel for our providers on the call who really get pressured a fair amount about antibiotics. What guidance could you give first to our providers on when is it appropriate to give antibiotics, or I suspect where you're going to go more importantly, when is it not appropriate?
Correct. So it is a very valid concern for parents to think that, okay, what is wrong with my child? I just feel that my child or my baby is sick all the time, especially if a child is going to daycare and being exposed to many viruses. I take it as sometimes as being sign of as a sign of being healthy. That means that your immune system is responding to foreign agents that are coming in contact with that infant, and then they're responding, and in a way is to say that they're creating that immunity. So as long as they're non-complicated viral infections, that the child, once the fever is down, is back to normal self and playing, that is a very reassuring sign. But I can understand the valid concern that the parents can have, and especially if my child is well for 1 week, and then I feel like it's just like boogers and runny nose for the whole winter.
So, and I take it you're talking about upper respiratory infections, which kids get a fair amount of. So how do if I'm a provider and I see a parent and they have a URI, and there really is pressure to get back to school, or there really is pressure to get back to the daycare, how do I make the visit less transactional and lower their expectations that an antibiotic is going to, 1, make their child better right away, and 2, is the right thing to do?
Correct. So this type of illnesses, as I mentioned, they're mostly viral. They're mostly caused by a virus, and so antibiotics are not the treatment for viruses. So the parent is concerned, and I think one of the very important issues to manage in this type of visit is to communicate well with parents, to give them the reassurance that, yes, your child is sick at this moment, may not feel well, may have like some fevers, not being in the best state of health. I acknowledge that. There are some symptoms that I can manage, like the fever, like the runny nose, maybe if there's like some cough, how to help parents manage that, but also reassure them that antibiotics would not make them feel better or would not treat the specific viral infection that they have.
And this is specifically after you do an exam and rule out any specific signs of bacterial infection, correct?
Exactly. We're talking probably with a child that the physical exam does not point into a complicated or a more serious bacterial infection.
Now, what about, I often get asked about temperatures, right? Fever. Is there a certain temperature that parents, especially if the fever is quite high, parents get more nervous about an illness? So does temperature at all weigh into the decision about antibiotics?
Exactly. So, first of all, is one of the things is to have a fever. Studies, and we make the recommendation of temperature above 100.4 Fahrenheit. That becomes a fever. So then parents can say, well, my child has a fever. Any temperature below that, we can probably ask the parent if they gave any antipyretic or any medication to lower the fever, to make sure that there was no fever at home, and then by the time they get seen, the fever has gone down.
And what is, a lot of times you do hear patients talk about we've seen children that have been on a lot of antibiotics. I think some of the things that can be used to advise parents is that antibiotics are not without their own consequences and side effects, right? So what are some of the things that we can tell our parents so that they're more educated about the potential negative side effects and aspects of antibiotic usage?
Exactly, Joe. I wanted to mention some numbers to show the importance of the antibiotic prescription. So a study that was conducted by the Pew Trusts and the CDC found that in the United States, approximately 150 million visits a year in adults and children have at least one antibiotic being prescribed in those visits. That accounts for 13% of all visits for outpatient visits in the U.S. And they also found that 30% of these antibiotics that were prescribed were considered unnecessary or not indicated based on the clinical findings on that. So it is important to know that there is an antibiotic overprescription in this case, and antibiotics are by no means, a 100% benign medication. They carry side effects as any other medication can have, and these side effects can be in the short term, can present in the short term. Adverse events more commonly seen are rashes, are GI disturbances like abdominal pain, diarrhea. The frequent use of antibiotics can develop to a more serious condition, which is the Clostridium difficile colitis, which is a more serious condition, but also can affect the blood cells, decreasing the neutrophils. Some antibiotics have the risk of creating renal problems, so they are by no means benign. And then in the long term, what we are seeing is the problem of antimicrobial resistance. That
superbugs,
yeah. What are called the superbugs? And one of the interesting data about the antibiotic prescription in the U.S. is that basically any child by the age of 2, about one child or every child in the U.S. by the age of 2 would have received at least one prescription for antibiotics in their lifetime.
Yeah, and I know the superbugs and the resistance, we read about that quite a bit. I know I've read research on how really a single episode or single course of antibiotics can affect the microbiome as well. Is that right?
Exactly. There are many studies on the microbiome, and especially those have been done in newborns, in premature babies that receive antibiotics in the NICU. And these works have shown that the colonization with this microbiome, or what we call the good bacteria, is completely different in those babies that have received antibiotics early in life. To this extent, we are not quite sure what would be the impact of that, but certainly those differences are going to create some sort of consequences. And also, and as I said, in the long term, we're probably seeing the children that are being exposed very early in their lives to multi-drug resistant to bacteria, to the superbugs. So those are children that are going to need, very specific antibiotic to treat multi-drug resistant infections.
Well, thanks. Yeah, I mean, you can't really pick up a magazine without reading about microbiome and the importance of your own flora in your gut, and certainly antibiotics disturb and can change that. So I appreciate that insight. Thanks. And I think that helps give our providers who are listening information that they can use with parents, because really that's throughout the lay literature. Okay, let's shift gears. We talked about when not to give antibiotics. So what are some of the things you can offer to the providers listening? What are some of the indications to give antibiotics? And if you want to do that by either severity or grade of illness, or if you want to go through some specific conditions, that'd be awesome as well.
Yeah, so you're absolutely right. I mean, we know that, for example, in children, vaccines have caused a decrease in the bacterial causes of infection, talking specifically about acute otitis media, about ear infections. Mainly the pneumococcal vaccine and the Haemophilus influenza type B vaccine have created a major impact in decreasing this type of infections. So mostly these ear infections are going to be viral. However, there are specific indications where we want to give antibiotics in this particular situation. For example, when there is an infant, when there's a child less than 2 years of age, we have to be more cautious because of the severity and the complications that can cause. So if we have a bilateral ear infection, that is an indication of treating with antibiotics in an infant. If we have, for example, a urinary tract infection, that is going to be an indication to treat with an antibiotic.
What about fluid behind the ears?
So fluid behind the ears, it depends on the clinical exam. It takes skills to make that diagnosis and to be able to visualize, and then also the severity of the illness. If we have fever for more than 48 hours, if we have pain, we have to check that the child, for example, is immunized, or if there's a guarantee of good compliance and follow-up. So parents still can be instructed in this type of situations on when we can wait and we can watch, and you can have a follow-up in a couple of days, and I can check the status of the ear to see if the patient needs antibiotics.
Great. Well, thank you. I know our colleagues in both the acute care world as well as primary care often see children with sore throats. and the question is strep or not strep, tonsillitis or not tonsillitis. And frequently the discussion of antibiotics comes up when it comes to sore throats. Can you shine some light on it for us, for our providers that are listening?
Yes. So absolutely, as I've mentioned, many times in this conversation, it's like the number one cause of pharyngitis is a virus. It's like viral pharyngitis. In school-age children, and mainly those like 4 years of age and older, then they start having the classic strep throat. And that presents, of course, with classic signs and symptoms that are not consistent or that do not represent a viral illness, a viral pharyngitis. So when we have like this type of clinical presentation, then a basic simple test, that is the strep test, the rapid strep test, would give us like valuable information in this patient to start the antibiotic or not. So we basically have the means to have an answer in a couple of minutes in order to start or to prescribe an antibiotic in this specific situation. On the contrary, kids that are less than 3 years of age is not routinely recommended to do this test. We know for many reasons that these patients, these children, do not get or do not have the receptors to create the complications of these infections. So then antibiotics or the test are not recommended.
So that's good to know. So children less than age 3 routinely should not be checked for strep throat. Is that what I heard?
Yes, that is correct.
Great. Okay. And what about, are there other symptoms that would lead you away from doing a rapid strep or a strep throat or a throat culture?
Cough, cough, the nasal discharge, and symptoms that are mainly consistent with a viral upper respiratory infection.
Great, thank you. I guess the last thing I would want to cover is blood cultures, or when do you culture, particularly for our colleagues who are working in urgent cares or perhaps ERs. Is there an indication for a blood culture in a certain population or a certain degree of illness? And what about, do you give antibiotics when you culture? Can you shed a little light on that information?
Yeah, so that would depend, especially on specific situations, and mainly the age of the child is one important factor to consider there. Then the next factor I would say is the severity of the illness, how the child is presenting. Are the viral signs abnormal? How many days of fevers have there been there? Blood cultures can be very valuable in patients, immunocompromised patients who have central lines and they present to an acute care setting. To determine if there's a line infection or if there's another bacteria causing more trouble there. They're not routinely recommended. For example, a patient that has clear signs of a viral URI and the fever is caused by an ear infection, we don't necessarily need to get blood cultures in this type of situation. So to summarize, I would say mainly the age. We want to get a blood culture along with other tests in newborns and in particular cases in some infants and toddlers, depending on the severity and the age as well.
Now, I know when I trained, which was just a few years ago, I guess, when I trained, we used that 8 weeks. You know, a true fever in a child less than 8 weeks was a cause for alarm and some real significant evaluations. Do we still use the 8 weeks, or has that shifted lower?
So, as of now, and they're like, every institution manages based on their risk. They establish their own criteria, but I would say that cutoff where no one has any doubt about it is the 4 weeks and below. But then, we have, what is a 5-week-old baby? What if the baby was not born full term? We're dealing with some situations that yes, we probably need to get a blood culture and a further evaluation.
So really use your clinical judgment, especially with those infants, is what it sounds like.
Exactly.
Great. Well, really, thank you for the information. I feel like we could talk about UTIs and VCUGs and bronchitis and pneumonia, and I think the list could go on and on, but really appreciate your insight. I know this is the pressure about antibiotics is really a real one that affects many of our providers, and they often have those somewhat difficult conversations with parents about why they're not prescribing an antibiotic. I guess to close up, I would ask you, when should a provider refer a patient specifically for an evaluation by a pediatric infectious disease physician like yourself?
Yes, Joe. And I want to hold on that question just to follow up on a comment that you just made in terms of providers probably feeling the pressure from the parents on wanting antibiotics. I would say to providers that parents want your expertise, or they're looking for your expertise and your expert advice, and they would follow most of the times whatever a provider has to say. And education and the language to communicate is key into reassuring the parents and saying, your child is ill right now, but I don't think your child needs antibiotics. And offer that follow-up opportunity and alternative. Give me a call in a couple of days, or I want to see you in a couple of days and see how things are going. And we'll determine if there is the need for antibiotic. Now going back to your question, yes, we do see referrals from our community. Definitely, one of the main things that we see is like prolonged fevers or recurrent infections. With prolonged fevers, what we see in these referrals are patients, children who have more than 1 week of fever, and despite laboratory workup, imaging, multiple physical exams, there's no clear evidence or where this infection is coming from. So we might be dealing with a more serious situation, and then yes, we would like to evaluate and see what are the risks and what are the potential infections or causes for these fevers. Then with the recurrent infections, as we talked about, that child that is probably sick all the time, sometimes those recurrent viral infections are not that concerning. But if my child is having positive blood cultures, if my child is having recurrent urinary infections or recurrent confirmed pneumonias with x-rays, then that's something that can raise a concern there. Is my child dealing with an immunodeficiency, or there is something wrong with the immune system that they're not able to respond well, or is causing these recurrent infections? Then basically, we also, in the region that we live, we have infections that are transmitted by animals and by insects, and those infections sometimes require like specific laboratory workup or specific imaging, and we would like to help into those infections to treat with the right antibiotic and establish the appropriate risk for that patient.
Good information. Thank you.
Dr. Sejlong, Dr. Boulouroudas, thank you so much for your expertise on this topic. Our Call to Care podcast series focusing on children continues with topics from appendicitis to joint pain and psychiatry and many more right here with our Sanford Health experts. Thank you both for being here. Thank you, those listening, and for all that you do. We'll see you soon.